Dear colleagues, Mr. Chairman, thank you very much for inviting me in this very interesting debate. So, is refractive surgery good for children? Is it a friend or a foe? I agree that refractive surgery has a role. It shouldn't be done to each and every anisometropic child, but it does have a role. So it is a change in concept. When indicated in the pediatric age group in children, refractive surgery is not aimed at cosmesis. It's not aesthetic. It does not aim to remove the spectacles and for the child to look better, but it's mainly functional. The aim is to salvage as much visual acuity to the child in an eye otherwise destined to amblyopia, even with amblyopia treatment, as I will try to explain in the next few minutes, and hence paving the way for binocular single vision and normal child development. It may be the most legitimate, medically indicated, and noble field of refractive surgery. Juvenile anisometropia affects 2 to 7% of the population. Freeman has identified amblyopic errors as antimetropia of more than 2 diopters if one eye is myopic and the other eye is hypermetropic. If there's more than 2 diopters difference, this is a stimulus for amblyopia. Isoametropia of 3 diopters or more in myopes, or 2 diopters or more in hypermetropes, and more than 2 diopters of cylindrical error difference between both eyes. The prevalence of any amblyopia defined as 2 or more optotype lines difference between the eyes in preschool children who have greater than 1 diopter of anisometropia is 66%, and this has been shown by a study that has been published in Ophthalmology in 2004. The prevalence of moderately severe 4 or more lines difference of amblyopia is 38%, and children with higher magnitudes of anisometropia have higher prevalence and greater depth of amblyopia. So what's the classic treatment of juvenile anisometropia? How to avoid or treat amblyopia if it happens in one eye? We do patching, we do penalization, plus spectacles and contact lenses, and they are very effective ways of treating the patients only if the patients and the parents are compliant. In our part of the world, we find a lot of non-compliance when it comes to treating juvenile anisometropic amblyopia. Not unfrequently, the scenario ends with improvement of visual acuity in the amblyopic eye, but on cessation of patching, some amblyopia recurs to the anisoconia of the spectacle correction. We then repeat the cycle again, and we go into different cycles, and the patient, when he reaches around 15 years of age, is in the neighborhood of 618. So in special needs, ametropic children, this is a very important arena in this field. A variety of neurobehavioral disorders impede spectacle wear. The most common are autism, with all the spectrum of autism, Down syndrome, moderate to severe cerebral palsy, and Angelman syndrome. In special needs children, the uncorrected ametropia exacerbates the neurobehavioral disorder. The child lives in a cocoon of blur, promoting fear and reduced interest in the outside world, a syndrome labeled visual autism. These children dislodge their glasses repeatedly despite heroic efforts from the parents' side to enforce compliance and from teachers and therapists. In these special subcategory of patients, many ophthalmologists, after examining a child with neurobehavioral disability, succumb to low expectations. They just surrender to the idea that this patient will live his life with a decreased amount of functional vision. The uncorrected vision is dismissed as good enough for a child with a handicap. Again, here refractive surgery may be godsend. So there is a paradox in classic teaching about anisoconia, and this paradox says that in patients with axial ametropia, you can treat them with spectacles, provided that the spectacles are at the anterior focal point of the eye, without inducing that much of anisoconia that will lead to double vision suppression and amblyopia. And this has been propagated by a very famous research that was done in Hanover from 1920 to 1945 under the leadership of the great Dr. Ames. His group concluded that axial anisometropia does not cause as much anisoconia as refractive anisometropia, but most cases of juvenile myopia that we see are actually axial. You can spot the child when he comes through the door by one eye being a little bit larger than the other. So high axial anisometropia can be managed by spectacles, and this has been the classic teaching. Until the published work of Gunther von Norden himself, the master, and he published it in the archives in 1970, and he proved that the presence of anisoconic amblyopia in monkeys with axial ametropia, not related to stretching of retinal elements or more than one synapse as was used to be believed before that. So will refractive surgery be the only treatment? No. The primary treatment must be patching to eliminate as much amblyopia as possible. And I have to say, these are very, very rare, occasional cases for the refractive surgeon. This is not a client base that the refractive surgeon wants to increase. Basically, these are patients that refractive surgeons are trying to help their colleagues, their pediatric ophthalmology colleagues, to treat. So in conclusion, is refractive surgery in children effective? In my opinion, yes, with a qualification. It is not the job of the refractive surgeon, nor that of the pediatric ophthalmologist, but of a team consisting of both. I think it is regarded as one of the most important and legitimate areas in ophthalmology, still an area of continuous research, and hence full disclosure and honest reporting of successes and failures is needed to fully understand its limitation. This was on the front page of Eurotimes in September 2001, and it was the best paper of the session in the Esquers of the same year, and it was the results of our study showing that LASIK is useful in juvenile anisometropia. Thank you so much.